Next, Dr. Kirkuti will return and will present point-of-care coagulation testing. I guess, critical topic.
Yeah. Great, thank you very much. It was an amazing talk. Thank you, Susan. So my disclosures again. So point-of-care coagulation testing disclosures. I think the most important disclosure I have here is that I'm not a hematologist. I'm an anesthesiologist. So when it comes down to questions, remember that. Lack of expertise is probably a disclosure here. So this is, I showed you this slide earlier, what we need to measure. It's complicated. We need to know what's happening at the site of injury, given all the considerations in terms of flow, size of the vessel, platelet fibrin interactions, depending on viscosity and flow and things like that. So this is what we want to measure, what we need to measure, but unfortunately we can't. What we can measure are the things I mentioned earlier. And if we're looking at coagulation measurement, I think it's good to go back to the old way of looking at coagulation, which is the extrinsic and intrinsic pathways, and then the common pathway in the middle there, followed with clot breakdown at the bottom. So this is not physiological, but this is how our lab tests are designed. I think that's an important message here. The lab tests that you look at have different reagents in them that are designed to test for some of these factors. They're not really physiological. So I've listed some of those tests there. For example, PT or INR for extrinsic pathway or the viscoelastic extem component of it. And then INTEM and PTT, for example, for the intrinsic and common pathway and so on. What you can see there that once you get to fibrinogen changing to fibrin, so beginning of clot formation, we really don't have any tests beyond viscoelastic testing, and I'll come back to that. But remember that all the tests we have really look at the beginning of clot formation. Now we have two types of tests, standard lab assays, so PT, PTT, fibrinogen level, CBC, and then we have the point-of-care coagulation assays, which include activated clotting time. I'm not going to talk about much, just one slide on that. Viscoelastic assays, which I'm going to spend most of the time on. Platelet function assays, which I'm not going to talk about much. And basically that's about it. So in terms of what we can measure, so heparin effect, you can use PTT for low-dose heparin, ACT for high-dose heparin, platelet count, CBC, and I have CBC both as point-of-care and standard laboratory, because you could actually do CBC point-of-care. Viscoelastic gives you a rough idea of what the platelet count is. I'll get back to that. Platelet function, there is no standard laboratory assay for platelet function, but we have multiple platelet function assays. And the issue there, though, is they're not really well validated. We use one for our cardiac surgery. There are many other ones. They use different activators. Whether or not they relate to a bleeding surgical patient, we're not 100% sure. You could spend a whole talk talking about platelet function and the different receptors and how we should measure them. We're not going to do that, but just know that there is platelet function assays. Platelet dysfunction, obviously, is relevant when patients are on antiplatelet medications. In terms of patients who are not on antiplatelet medications, in cardiac surgery it's a significant issue, but less and less so because our pumps are now substantially better than they used to be a generation ago. In trauma, there might be some role in platelet dysfunction. We're getting evidence on that more and more every day, but for now, really it's not a consideration for most of the bleeding in surgery. Thrombin generation I mentioned earlier, there is no way to measure it in its entirely clinically, except for we get some information from PT and PTT, and similarly from viscoelastic testing, we get clotting time, CFT, and alpha angle. And also you can do point-of-care PT and PTT, so it falls on both sides. Fibrinogen, you've got fibrinogen assays in plasma, or you can do whole blood fibrinogen assays or viscoelastic assays. And then fibrinolysis, there is no standard assays that are clinically useful in the operating room, but we got the viscoelastic assay. So that's the difference between the different tests that we have. But what about the relative advantages and disadvantages? So as I mentioned, we want to know what's happening at the site of injury. We can't do that. So the next best thing to do is what's happening in terms of clotting in whole blood, which is where the point-of-care coagulation assays come into play. And then the one step removed from that is standard laboratory tests that are usually done on plasma. So the blood gets centrifuge, plasma gets separated, so you see what the levels are in plasma. So it's multiple levels removed from where we need to be. But that explains primarily why point-of-care tests are better. They give you more information because they're in whole blood, and they give that information to you faster. So plasma-based, you got to spin the blood, send it to the lab, and wait for it to, I don't know about your hospitals, but for us, even getting a CBC back, which is not spun, takes about 20 minutes or so, and about 45 minutes for INR, PTT, and fibrinogen. If we're lucky, we might get it back in half an hour. Whereas whole blood-based point-of-care assays, you can have initial results within 5 minutes of running the test. Standard assays are more reliable because they're done in plasma, they're standardized. There's good gold standards to know if your lab is functioning, giving you accurate results. So if I get an INR from the lab, I know at 2.2 what it means, how much Coumadin the patient should get, and so on. Whereas with point-of-care, they're more variable. There is no definitive gold standard to compare them to, and there's interference in them because they're in whole blood and they're not in plasma. So you got to keep that in mind when you're interpreting point-of-care assays. The numbers don't mean the same thing as they do in standard lab assays. They're helpful, they can guide you, but you really can't, for example, dose Coumadin or reversal of Coumadin based on a point-of-care INR or viscoelastic assay, for example. Normal ranges are well established in standard laboratory assays, but they're not in point-of-care assays, and they're different for everything. Even viscoelastic assays, whether or not you do ROTEM versus TEG or other ones, they have different normal levels. What they mean to different types of surgery, we don't know. Where the thresholds should be for instituting treatment, we don't really have good data on that. So there's a lot of unknowns for point-of-care assays. And then finally, as I mentioned in the last slide, with lab assays, standard assays, we get information up to initiation of clot formation. Whereas with point-of-care assays, specifically viscoelastic assays, we get the whole clotting process. And that really becomes evident when we look at the phases of coagulation. So on the x-axis, you have the time, and on the y-axis, you have thrombin generation. The red line is the thrombin generation that you can use. So you can actually measure thrombin generation not in the OR, but if you spin the blood, freeze it, send it to an experimental lab, they can give this to you a couple of weeks later. So you can see what the patient's thrombin generation is. So it takes about a minute or two to start the process. Then you get the burst of thrombin generation. And then you get, the blue line is fibrin formation. So you get clot formation, which takes about 7 to 10 minutes. One of the things I tell the surgeons when I'm trying to manage bleeding is after every step, you've got to wait about 10 minutes before you know it's worked or not. And surgeons and anesthetists are pretty impatient, I find. So the hardest thing to do is, one of the most effective ways I have in managing bleeding in the operating room is to drag my feet. And I always tell the residents and fellows to, okay, drag your feet here. You've given one intervention. You've got to find a way of delaying things for 10 minutes until you give another intervention. Anyway, that's the reason. It takes about 10 minutes for a clot to form. So even if you fixed it, you've got to give it some time. But going back to the original reason I put this slide up, when you look at the parts of the clot you can measure, so if you look at PT, PTT, on the top right, you'll see, as I mentioned, once you start getting fibrin formation, that's the usefulness of PT, PTT. But if you translate that into the clot formation, you'll see all the things you're missing after you have your INR or your PTT, which is all the other thrombin generation, or 95% of your thrombin generation. So you could have a patient with a relatively normal INR and really bad thrombin peak and area under the curve in that thrombogram, and you wouldn't know it. And we really don't have any good assays to detect that. So keep that in mind when we're interpreting coagulation assays. On the other hand, if you look at viscoelastic assays, so this is a ROTEM curve. So at the same time point where PT-PTT stops is where really the 95% of the ROTEM measure is still ongoing in terms of maximum clot firmness, clot breakdown, the alpha angle, clot formation time, and so on. So you get a lot more numbers and information out of viscoelastic assays than you would out of the standard coagulation assays. Just a couple of points on PTT. So you can do point-of-care PTT or standard PTT. It's designed, as I mentioned, it's designed to measure intrinsic and common pathways. So it's activated with kaolin usually, so you get the surface factor 12 activation, and you get all those red circled factors that go into what an elevated PTT would be. And if any of those drop below 40%, then your PTT is elevated. Importantly, it's not as sensitive by design to vitamin K dependent factors, which is what we do an INR for, but it is very sensitive to heparin, which is why we primarily use it for. It's also sensitive to the presence of circulating inhibitors like lupus anticoagulant, which is why when your PTT is elevated and your patient's not on heparin, that should be the number one diagnosis. Anyway, the point of this slide is to remember that basic PTT is designed to measure the factors on the left side. It doesn't tell you which factor is low, but generally if they drop below 40%, or if the patient's on heparin, PTT is going to be elevated. INR, on the other hand, is designed to measure the extrinsic factors and the common pathway. Now, the activator they use is thromboplastin. It activates factor 7A, but it's also factor 7, so you get factor 7A. And it's elevated if any of those factors drop below 50% normal. Now, the assays that we use have something added to them that inhibits heparin effect. So polybrine or heparinase are added to them, so that low doses of heparin do not increase your INR. So it's not the only reason when patients on heparin and you get a good INR reading is because of the way the assay is designed. Some don't have that heparin reversal agent, neutralizing agent. So it's important to know what does, but most labs use it so INR doesn't get influenced by low dose heparin levels. Now, the relationship between INR and factor levels is important. As I mentioned in our last study, we use actually INR to determine if patients have coagulation factor deficiency, and that's based on curves like this. So once your INR is elevated, which is that second set of dots from the left, INR range 1.6 to 2.0, so it's more than 1.5, you can see your factor 10 level is already down to 20%. Other factors are around 50%. So an elevated INR means your factor levels are low. I know a lot of our hematologists say don't treat an INR unless it's 2 or 1.8 and so on. By the time you get to 1.8 or 2, you can see that basically you're now down to 40% factor levels. Factor 10 is dropped to about 10%. So in my view, if someone's bleeding and the INR is over 1.5, then it needs to be treated, and you ruled out other causes, then it should be treated. I think waiting for a 2 or 1.8 is probably too high. If they're not bleeding, as you heard Susan say, do not treat the number. So high INR in a non-bleeding patient means that's perfectly fine. You don't need to treat it, or low platelet, or low fibrinogen, or whatever the abnormality might be. But if it is high and the patient's bleeding, then it should be treated. Just one slide on, I always get asked in terms of what the difference is between PTT and ACT. And this slide, I think, clearly illustrates it. So PTT measures low-dose heparin levels, and ACT is designed to measure impact of high-dose heparin levels. So this is a study where they gave 2,000 of heparin, so not a high dose at all, and they looked at PTT and activated clotting time. So the white dots are the pre-heparin administration. So your PTT is normal in every case, and your ACT is in a range of less than 150 or so. Once you give the 2,000, you can see the ACT has gone up, your PTT has gone up, but look at all the dots right at the top where they're above 150 of PTT. So PTT doesn't tell you anything about it. So 2,000 units of heparin puts your PTT above the threshold, whereas ACT still gives you a useful number. And that's what we use, for example, when we use high-dose heparin for going on pump in vascular surgery when we're doing stents and so on. So that's the difference. PTT is for low-dose heparin management, ACT is for high-dose heparin management. Now you heard a lot about blood conservation. Bleeding patients is one of those indications where you need high transfusion triggers, and this is the reason why. So I like to say that hemoglobin is a coagulation assay. The lower your hemoglobin, the worse your platelet function, and therefore if the patient's bleeding and coagulopathic, then it makes sense to have higher hemoglobin levels. And that's kind of a linear relationship. So the higher your hemoglobin, the higher your platelet function, and the reasons for that are listed there. RBCs promote platelet margination, they increase platelet and thrombus interactions, and enhance platelet adhesion and activation, particularly in high shear rates. So if you have arterial bleeding, you need good platelet plugs to form, which means you need good platelet activation, which means you need high hemoglobin levels. Now, what should that be? Obviously, it's linear, but you don't want to over-transfuse. So usually what I aim for in a bleeding patient is 9 to 10 grams per deciliter, as opposed to the 7 to 8 that would be standard in a non-bleeding patient. And if you notice the slides before, most of the studies of restrictive versus liberal, almost all of them actually excluded unstable or bleeding patients. In a bleeding patient, transfusion trigger should be higher because hemoglobin is an important hemostatic agent. Now, going on to viscoelastic assays, I'll go over ROTEM specifically in terms of trying to explain what they actually measure, but you could use any of these things. We just happen to use ROTEM at our organization. Now, I'm just wondering if we could have a show of hands in terms of how many people are familiar with viscoelastic assays and or using it routinely. Okay, so still the majority here are not, so that's good because I'm not going to be wasting your time by explaining. Some of you I'm going to be wasting your time. Apologies for that. But I'm just going to explain a little bit about what we're measuring and then finish the talk with a couple of cases of postpartum hemorrhage using viscoelastic assays. So when you do a ROTEM or any viscoelastic assay, most of them work like this. So the blood goes in a little container, and then the graphic representation of how that clot is formed comes out. So clotting time is from the time you start the assay until clot starts forming. As I mentioned, that's analogous to INR. So that's clotting time. After that, you get the clot formation time, which is the time it takes from clot formation to reach 20 millimeters. And then the angle of that time is also called the alpha angle. Then you get for maximum clot firmness, and you can estimate them MCF by the A5 and A10. They're highly correlated, and the normal values differ based on that correlation. But it allows us to determine the abnormalities much earlier than having to wait for the maximum clot firmness, which would probably take 15 to 20 minutes. So after 5 minutes of clot formation, and then add another couple of minutes for clotting time, so about 6 to 7 minutes, you start getting a good idea of what coagulation is going to look like. And then you wait for maximum lysis or lysis index to see how much clot is being broken down. And each one of those things measure a different thing. So clotting time measures the coagulation factors or thrombin generation. Maximum clot firmness measures platelets and fibrinogen contributions to clot formation. And then breakdown, obviously, is fibrinolysis. When you compare the different machines that are out there, so there isn't that much data out there. This is one of the ones I could find that compares ROTEM with Quantro and TEG. Now, this is how they compare for platelet count. So on the x-axis, we have platelet count. On the y-axis, we have ROTEM. And you can see they're kind of similar, but what really stands out here is you really can't use any of these assays to determine what the patient's exact platelet count is. It's quite a bit of variability. For example, in the middle there, you could have a Quantra of 20 that could have a platelet count of 280 versus about 150 or so. So it's quite variable. But in general, they correlate well. So the higher that whatever value is that the point of care assay is measuring, the risk, so in terms of ROTEM, XTEM minus FIPTEM, the higher your platelet count is. They're much better for fibrinogen levels, but again, only in identifying who's got low fibrinogen levels, not to determine if, in terms of, yes, you're equivalent to 2.2 versus 2.5 versus 4. In ROTEM, we've done a study that shows that if your FIPTEM, and I'll get to that in a second, which is the component that measures fibrinogen, is less than 8 millimeters, you almost definitely have a fibrinogen that's less than 1.5. And if it's more than 12, you almost definitely have something that's over 2, but you really can't be sure 100% of the time. So with that caveat, we use, you can see that they have pretty good correlation with fibrinogen levels. Now this is what a ROTEM assay, if you get a cartridge base, this is usually what you get. So you get the XTEM on the top right, FIPTEM, and then INTEM and HEPTEM. So XTEM is the extrinsic pathway. So it's got tissue factor. It's analogous to the INR, for example, as I mentioned in the clotting time. And it's got polybrine to block in heparin effect. So you could use it on heparinized samples. FIPTEM is the same as XTEM, except it's got an antiplatelet thing in there to eliminate the influence of platelets on clot formation. So if you look at the FIPTEM and the XTEM together, you get an idea of how much of your clot formation is due to fibrinogen levels or platelet counts. Importantly, the activators here inhibit or mask platelet inhibition. So if you think you're going to identify platelet dysfunction with viscoelastic assays, you're not. You could have a perfectly normal viscoelastic assay and severe platelet dysfunction. As long as the platelet count is good, you're going to get a normal ROTEM, which is why I think in areas where you do have platelet dysfunction, it's important to actually measure platelet function. Anyway, XTEM and FIPTEM. And then in INTEM, it's the intrinsic pathway, and HEPTEM is the same as INTEM, except it's got heparinase in it. So you could use it to determine to see if there is any heparin in a patient by comparing the clotting time of the two curves. And then APTEM, which is not part of their usual cartridge, is XTEM plus aprotein or tranexamic acid to give you a fast visualization of whether the patient needs antifibrinolytics. So how do we use viscoelastic acids? So fibrinolysis management is one of them. Importantly, when it's normal doesn't mean the patient doesn't have fibrinolysis. It's not that sensitive. You could still have clinically significant fibrinolysis, but not detected on ROTEM or viscoelastic acids, which is important. Why it's important to give tranexamic acid and not wait for confirmation with viscoelastic assays before treating in high-risk cases. But when they do have significant fibrinolysis, it's pretty, when you do identify it, it's pretty easy to diagnose, which is what you have on the left side there. And then conversely, you can have shutdown fibrinolysis, which is more and more recognized to occur in a small subgroup of trauma patients who are at risk of thromboembolic events. So it's really good for identifying in trauma, for example, potentially which patients shouldn't get tranexamic acid. Clot firmness, remember I mentioned it measures platelet count and fibrinogen levels. So that's normal, so XTEM and FIPTEM in the bottom. Here you have a situation where the maximum clot firmness and A5 and A10 are all reduced, and your FIPTEM is also reduced. So this patient has low fibrinogen, but could also have low platelets. We don't know for sure, because whether or not all that reduction in MCF is due to low FIPTEM or not, you can't really tell. So there's the ambiguity that you get in viscoelastic assays. In this one, though, that ambiguity is gone because your FIPTEM is actually pretty normal, but your MCF or your A5 and A10 are below normal, which means that it's low platelet count. So you have normal fibrinogen, low MCF or A5 and A10, so you have low platelet count. You don't know what it is, but it's lower than normal. So in terms of coagulation management, thrombin generation management, so this is coagulation factors. So clotting time is relevant here, and clot formation time and alpha angle. So normal XTEM and HEPTEM on the bottom. And you can see the clotting time is elevated here, but everything else is normal. So this could either be a false positive, or it could be a patient who's got isolated coagulation factor deficiency, so vitamin K dependent factors could be deficient, so patient on Coumadin might present like this. And then here's where it's more obvious, where pretty much everything's abnormal. So it's not specific, but when you have elevated clotting time and elevated clot formation time, and your maximum amplitude is low and so on, it's a pretty good indication that at least a component of this bleeding is due to low coagulation factors. We can use viscoelastic assays for heparin protamine management. So this is the INTEM on top and HEPTEM in the bottom. Here is where the clotting time becomes really important. INTEM clotting time on the top, you can see on the left, is substantially prolonged. And then in the heptem that has heparinase that eliminates that impact, you'll see the clotting time is normalized. So the ratio of clotting time in intem over heptem, if it's more than 1, then that means there is residual heparin on board. And it would be good. This is a good way to diagnose post-pump bleeding if you're worried about heparin rebound, for example. And then, importantly, if you give too much protamine, we also know that's an anticoagulant, so you get the thrombin generation problem, low platelet problem. So essentially, it becomes an abnormal ROTEM or viscoelastic assay, general abnormality, because you've kind of messed up coagulation in general by giving too much protamine. And this is not a little bit of extra protamine. To get a picture of like this, you've got to give like substantially more protamine than needed for a heparinized patient. And then you've got hypercoagulability, which is easy to recognize. There's 2 types. So this is normal extem and fibtem. On the left, you have hypercoagulability with fibrinolysis. That's physiological. And maximum lysis there you'll see is at 7% in extem. So the clot is still breaking down over time, as you would expect, but it's very hypercoagulable. The patient is very hypercoagulable. And on the right side, the difference is you don't see that breakdown of the clot. There is no lysis. This would be a hypercoagulability with fibrinolysis shutdown. This is a sort of a picture we saw with COVID patients in ICU that we didn't see much in any condition before that. So this really came to the forefront after the COVID pandemic or during the COVID pandemic. Just to reiterate some of the limitations I've already mentioned, so they're unable, viscoelastic assays do not detect platelet dysfunction due to the overwhelming effect of thrombin activation that they initiate to get the clots going in a timely manner. They lack sensitivity for detection of direct oral anticoagulants, direct thrombin inhibitors, and warfarin, so you really can't use it to determine whether or not patients are on these drugs or whether or not they need reversal. They lack sensitivity for von Willebrand disease or low von Willebrand factor because to detect that you need high shear stress and collagen exposure, which these assays do not do, so you might miss that. They also aren't very good at detecting factor 13 deficiency, although the breakdown might give you some information on that. So if you have a normal coagulation and the clinical situation suggests that von Willebrand factor deficiency or factor 13 deficiency might be a factor, then you've got to keep that in mind. And they're unable to rule out clinically significant hyperfibrinolysis. So just because you have normal viscoelastic doesn't mean and the patient's bleeding doesn't mean you shouldn't give tranexamic acid. As you heard, there are multiple different algorithms out there. This is a review article that looks at, for example, here's one on cardiovascular bleeding using viscoelastic assays. There's another one for liver transplants. So they're all different thresholds. They have another one on trauma and postpartum hemorrhage. What's important, I think, is for you to have, and these are complicated and really clinicians don't follow these. So you need to have simplified management algorithms, just like you saw previously for pediatrics. I think it's important to have localized ones that you're familiar with as opposed to going necessarily with what's published. There's a simple one for cardiac surgery by the SCA, published a few years ago now, but it's pretty straightforward. I would change this based on recent evidence, but that's not relevant to this talk. But you can have simplified as point-of-care based algorithms for managing patients. And we do know, as I mentioned, that having point-of-care based algorithms actually improves outcomes. Some of the limitations of these assays, they're based on specific cutoffs. As I mentioned earlier, these cutoffs are not well studied, so keep that in mind. They usually recommend stepwise management based on these selected cutoffs, whereas in some cases you might want to deviate from that depending on severity of bleeding. They don't use all the information you get from the assays. They only use to keep it simple, small components. So once you learn how those graphs are, you can actually tell a lot more from the actual graph, how it looks, as opposed to the numbers that comes from it. And they don't really consider the clinical scenario in terms of patients' comorbidities and severity of bleeding. All they say is if they have microvascular bleeding or not. And most importantly, I think they treat dynamic rich assays as very specific measures. So you lose a lot of information by following the algorithms. I have 1 minute left, so just a couple of cases on postpartum hemorrhage. So delivery room at midnight, you're faced with a patient who's having bleeding, has estimated blood loss is 1,500. You do a ROTEM, and this is what you get. So already you can see the XTEM looks pretty good. The FIPTEM is looking kind of narrow, and it's flattening out, so you know that's going to be low. So this has only been running about 5 minutes now. You already have a pretty good idea in terms of what's happening here. And the INTEM looks okay, and the APTEM is very similar to the XTEM, which suggests there's no fibrinolysis that you can detect with the ROTEM here anyway. So that's what the curves look like. So FIPTEM is 5. So the normal, remember I said anything below 8 is low fibrinogen level. And XTEM is 30, clotting time is pretty good, and INTEM is pretty good. So the question comes, what is or are the best interventions? So and usually this is more interactive, but this is too big. So I think low fibrinogen would tell you that D is the right answer here. But also I think A, if you haven't given tranexamic acid to a bleeding postpartum hemorrhage patient, I think it merits it. So A and D I think would be here. And you saw the result here. I mean, the tranexamic acid should be you don't need an assay for that, you give it. But the FIPTEM being low, you would have known within 5 minutes. Whereas if you wait for the lab to get this back to you, this would be another 40 minutes or so. And now with fibrinogen concentrate available, you can treat it, identify and treat it within 5 to 10 minutes as opposed to an hour, which it would have been otherwise. So you give the tranexamic acid and fibrinogen, and your FIPTEM has thickened there, so everything is normal. And then the next case, same situation, except you get this viscoelastic assay, which, as you can already tell, is actually pretty robust. So I'm not going to run because I'm out of time, but basically there is no heparin on board, everything looks good, FIPTEM is good, so fibrinogen is good. This is a normal coagulation parameter with ROTEM, which means you should look for a source of bleeding, and in this case, they treated uterine atony, and it stopped the bleeding. So it's a good way to rule out coagulopathy also. And you could also give tranexamic acid if you wanted to, but a little bit of oxytocin fixed the problem, and that was it. And with that, I'm going to stop. Thank you.